Sir, good evening.
Good evening. Somehow my video is having some trouble. I'm not sure what is the problem. I tried setting, but it doesn't work.
Good evening, Rasik sir.
Good evening.
Hi, Ravi. Hi, Vijay. Good.
Just coming.
There's some problem with video part, video setting.
Sir, Rasik sir, you are admin. You are admin of this meeting.
No. I mean, I don't know how to start my video. That means there is some problem. If I put my mobile, it will come, but not on laptop.
सर एग्जिट करके वापस इन करिए ना.
नहीं, वो सुबह में भी प्रॉब्लम हुआ, तो देर इज सम सेटिंग इश्यूज विच आई हैव टू अंडरस्टैंड. वो ठीक है, वो नहीं रहेगा तो काम तो हो जाएगा अपना. So Manoj will start and you can end, Vijay.
सर ओके, नो इशू सर.
Yeah. ऊपर कैमरे का शटर तो ऑफ नहीं है सर आपका?
नहीं, वो प्रॉब्लम नहीं. देयर इज समथिंग इन द सेटिंग. बेसिकली सिलेक्ट ए कैमरा एंड देन दैट देयर इज फेस टाइम HD कैमरा built in. So I did that, but then there is something else. टेक्निकल सब इतना. और वो ये एप्पल मैकबुक का सब सॉफ्टवेयर चेंज होते रहता है ना, तो कुछ तो हुआ रहेगा, उन्होंने कुछ किया रहेगा और कुछ वापस एडजस्ट करना पड़ता रहेगा.
Hello. Yeah, I'm audible?
Yeah.
Yeah. So, warm greetings and good evening to all the distinguished participants. On behalf of this editorial board of the GIAPS, we welcome you to this 11th episode of GIAPS Abhigyan, which we all know as a collaborative learning platform for all of us. Before we start the proceedings and hand over to the moderators, I would like to invite our editor-in-chief, Dr. Rasik Shah sir, for his inaugural comments.
Yeah.
Please. Yeah.
Thank you, Vijay. My video is not going to display. Just Arvind has called up, so I will just speak to Arvind. Arvind, you can join. You can join Abhigyan. Okay. Yeah. So Arvind will join in a minute. Yeah. So we had a very good meeting at Puri annual conference of IAPS, and we had good celebration of 30 years of JIAPS, where we felicitated past editor-in-chief, reviewers, proofreaders, all those who had won best paper prize over last 1 year in JIAPS Abhigyan. And I requested at that time to give at least 10, 15, 20 minutes for JIAPS in each conference, where we can tell about the progress of JIAPS over last few years. So it was overall a good meeting, and I think JIAPS has become mature now. and we will see over the next decade how we are progressing in compared to some of the international our pediatric surgery journals. I thank all of you, those who have joined and not joined, all members of IAPS for supporting JIAPS in a big way. Without their support, we would not have reached to this milestone of 30 years, more than 400 papers submitted in last 11 months, and many more will come. This year we have published 166 articles, and next year it will be around, I am assuming it will be around anywhere between 225 to 250. We may separate out case report journal. I have a meeting with our publisher on Friday where we'll discuss some of the aspects, and we'll see how is the financial burden for starting a second journal. And if feasible, we may able to start in another few months, because the number of submission of case report have almost doubled in 25 as compared to 24. And these are all our members' case reports, and we will like to accept that rather than deny them. We may not be able to accommodate all these case reports in the present journal. So the another journal of case report will certainly help us. With these remarks, I again thank all of you for submitting articles in JIAPS. I thank Yogesh and Sushmita to be moderator for this particular session, selecting 3 good articles. And I'll hand over back to Vijay, not Vijay, but Manoj, to continue with the proceedings.
Thank you, sir, for those valuable information. This happens to be the last Abhigyan meeting of this year, but perhaps the first of our new EC, IAPS, who has joined after this conference. So we welcome the new SG IAPS, Dr. Arvind Sinha, to this meeting as in a new role. Welcome, Dr. Arvind Sinha. And Dr. Honorable President, Dr. HPS Piglani, who is traveling, so he is not able to join. We are happy to introduce actually Dr. Yogesh Sareen and Dr. Sushmita Bhatnagar, madam, who has joined as our esteemed moderators for this session and has selected 3 manuscript for that. So I would like to hand over.
Before you hand over, let Arvind give a remarks, because the president is not there.
Okay.
Arvind.
Yes, sir. Ani, I think thank you, Rasiksha sir, for giving me an opportunity to be here. And I think our journal has been doing wonderfully well. And I think each one of us has seen the change and increase in the quality of the manuscript. And this initiative of Abhigyan, where we discuss papers, good papers, that is another feather in the cap of the editorial board, and definitely by reflected glory to IAPS. I wish, right, I think we can continue with that, sir.
Thank you, Arvind, for those remarks. And our means both of the moderators actually needs no introduction, so I will hand over the proceedings to Dr. Yogesh Sareen and Sushmita Bhatnagar, madam. Please take over.
Yeah, so as I already mentioned just before you started recording, the 3 papers that were selected this time were all very different, and they offered something new that we had not kind of read before. Let them present, and I have reviewed them very, very closely as a research paper, and jotted down their strengths and limitations of the papers. Most of the papers have actually mentioned most of the limitations that I'm going to talk about, but some other limitations which I could see, I can mention that. There are a lot of strengths, that's why they were chosen. So I think we can ask the first paper to be presented, that is Nurse-Led Intervention Program Builds Confidence Regarding Home Care Among Mothers of Solid Organ Tumors Children. This is from College of Nursing, All India Institute of Medical Sciences, Department of Pediatric Surgery, All India Institute of Medical Sciences, College of Nursing, All India Institute of Medical Sciences, Jammu. I think Dr. Shashi Mawar, she is going to present today. Is that right?
Yes. Yes.
Right. So you can go on with your presentation and please try to finish in 8-10 minutes. Thank you so much.
So can I share my screen?
Yes, please.
Says host has disabled the participant screen sharing.
Vijay,
Madam,
Yeah.
please try again, madam.
you're the co-host now, please.
You have been made co-host. Please try again.
Yeah, is my screen visible?
Yes, ma'am. Very much. Can you put this on presentation?
Yes, yes.
Slideshow. Yeah.
You need the slideshow. Yeah, just press that button. Yeah. Yeah.
So basically, I'm going to present about a nurse-led intervention program which builds confidence regarding home care among mothers of solid organ tumor children. And as you all know, that cancer remains a major health challenge. And mothers being the primary caregivers in the homes, they have some low confidence as well as limited knowledge, which hinders the recovery and exacerbates stress among the mothers as well as children. So video-based programs, they have shown promising and results in enhancing the mother's knowledge and confidence, which we have tried out in our setting. So the aim of this study was to evaluate the impact of nurse-led intervention program on the knowledge and confidence of mothers regarding home-based care of children with solid organ tumor. It was a quasi-experimental study with a non-equivalent control group design. The population was mothers of children with solid organ tumor, and which convenient sampling method was used. And the sample was from the children who were admitted in pediatric surgery wards. Knowledge we referred as the factual information related to home-based care of children of these mothers. Confidence was the mother's faith in self-ability to provide this care. Effectiveness was improvement in knowledge and confidence of mothers. And nurse-led intervention basically included several aspects of the care, which included cleanliness, post-surgical wound care, nutrition, oral care, knowledge of danger signs, precautions, complications, schedule of vaccinations, and follow-up. And this was provided through a video-based teaching program, and a supplementary information was given through pamphlets also. And the mother was defined as the person who was involved in direct care of the children, both at the hospital and at home. The inclusion and exclusion criteria of this study included children between 0 to 18 years of age who were admitted in pediatric surgery, and mothers who were able to comprehend English or Hindi. And those children, they were excluded with CNS tumors, as well as those who were not willing to participate in the study, and those having any other comorbidities. The sample size was determined using the G-Power 3.1 software based on the pilot study data, employing a two-tailed test with an effect size of 0.88, alpha level of 0.05, and power of 0.95. Though this was a small sample size, but it was sufficient for it was not sufficient for detecting large effect sizes, so it may be underpowered to detect the minor effects or subgroup differences. The tools for data collection which were there for this present study, they were demographic data sheets, knowledge questionnaire for the mothers, and the Likert scale was there to assess the of mothers having children with solid organ tumor. If we look at the validity and reliability of the developed questionnaires, the CVI score was 0.98, and reliability was calculated using a split half method for knowledge questionnaire, which was 0.82, and for the confidence, it was Cronbeck alpha, and it was 0.81. This nurse-led intervention was a video presentation as well as a pamphlet, and it was there both in English as well as Hindi. The components I've already mentioned, and the pamphlet again included some more information on management of complications and side effects of chemotherapy. And if there were any doubts from any of the mother or any other relative, they were clarified on one-to-one basis. And these are the glimpses of the video teaching, which included the post-operative care, the chemotherapy care, and this was the pamphlet from front and back. The ethical permission was taken from the ethics committee, and CTR registration was also done. After obtaining this institute's ethical consent, we assessed the eligible candidates, and we divided into experimental and control group on 1:1 ratio, on as it was a convenient sampling. And from both the groups, baseline data was collected and a pretest was done for knowledge as well as confidence. And for the experimental group, the home-based teaching was provided, whereas for the control group, a standard care was provided. And for both the groups, a post-test was done after 1 week as well as after 4 weeks. And after 4 weeks, an analysis was done. So for data analysis, the data was entered into the Microsoft Excel sheet, and it was done using Stata version 16.1, and the level of significance taken was 0.05. If we look at the demographic characteristics of the mother, both the groups were homogeneous. If we talk about age, education, occupation, as well as socioeconomic status. And if you look at the characteristics of the children also, they were similar for age, gender, and number of siblings, and any other sibling affected. They were similar. And these are the clinical variables, that is how many, both the groups were again similar for receiving chemotherapy before surgery, after surgery, and whether they required surgery or not, and the number of chemotherapy cycles. So both the groups were homogeneous. If we compare the knowledge score in experimental and the control group, it was seen that at week 1, the mean knowledge score was 20.7 versus 12.8 compared to the control group. And even at week 4, that is during the post-test 2, it was 19.5 compared to 12.6. So there was a significant increase in the knowledge scores in the experimental group compared to the control group. And if we see the knowledge, confidence level of these children in the chemotherapy group, again, it was 22, the median was 22 versus 11 in the experimental and control group at week 1, which was again significantly higher in the experimental group. And even at week 4, it was 20 versus 10. So again, it was significantly higher. And even in the post-operative group of children also, the median was 21 versus 10 in the experimental and control group. And at 4 weeks, again, 19 versus 18, which were again higher in the experimental group compared to the control group. There was a significant positive relationship between the knowledge and the confidence, as shown by R of 0.525. And also in the post-operative group, that is the knowledge and the confidence that was positively correlated. So the empirical evidence from this study illuminates the substantial benefits of such interventions, aligning with Rahmani et al.'s findings also. And it also resonates with the extent of literature, which marks a significant step towards the patient-centered care. The educational attainment among the mothers in this cohort was notably high, resonating with the findings of Parke et al., which again indicated a significant proportion of graduate level education among mothers. Occupational status predominantly identified mothers as homemakers, and which was also consistent with Rahmani et al.'s observations. In the current study, there was an increase in maternal knowledge scores reflecting the effectiveness of the structured nurse-led video-based educational program. And this was also consistent with Kaur et al. As well as Chang et al., who also have observed significant knowledge gains among this group. Our study revealed a substantial enhancement in maternal confidence as well. And this also aligns with the results of Fredenberg et al. the correlation analysis showed a significant positive relationship. Again, this reinforces the hypothesis that educational interventions that increase maternal knowledge can also enhance caregiver confidence. However, the present study identified no significant correlations between the mother's knowledge and the selected demographic variables, and it diverges from Almonium Sen et al. Study, who reported significant associations between maternal education and occupation and overall knowledge scores. So the limitations of our study, it was a small sample size and lack of randomization. And as I already said that it was a quasi-experimental study. So this is a limitation of a quasi-experimental study. So to conclude, video-based nursing intervention was effective for increasing the knowledge and confidence among the mothers of children with solid organ tumor for imparting home-based care. Therefore, the healthcare providers should consider implementing this intervention to improve quality of home-based care for children with solid organ tumor. Home-based care for all diseases should be part of discharge teaching for the children. These are my references. Thank you, everyone.
Thank you, Dr. Mawar. Dr. Bhatnagar, if you would like to say something before I read out the detailed summary or my observations about the paper.
Yeah, there are some queries that I had. One is this convenience sampling. Why did you choose convenience sampling?
And sampling because since all the children, they were in the same ward, it was very difficult to randomize. Otherwise, they'll be anyway sharing the information with the neighboring beds. So
That is, but as per the paper, as per the article that has been published, I think there is a discrepancy between what you presented over here versus what is there in the article in terms of the sampling, in terms of the education of the mothers. That mentions, your article mentions that for the first sample, the control group, most of them were graduates.
yes,
And
most of them.
they were postgraduates. So,
Yes.
so that was one point that I wanted to highlight. Another thing is, how many complications in your study could you find that you could avoid by using this intervention? So my point in asking you this question is, you already know that this video and pamphlet education to the mothers, whether it is nurse led or doctor led or whoever, like it helps in home based care. We know that, right? There are so many references that you have given already. So, what was the main purpose and what did you avoid? What complications could you avoid by doing this nurse-led intervention?
In this group, most of the children, they just came for the regular follow-up. Nobody came for any other kind of complications, and we did not follow these children after 4 weeks. So during those 4 weeks, we did not find any complications when they had come for the follow-up.
Okay, so can I suggest that once you have this baseline, maybe you can do a detailed study in which you actually prove that there is that these many complications or so and so complications and the percentage of it have been prevented by the interventions that we are doing, because these are quite meaning they quite one-to-one extensive interventions that we need to do, and it takes time, it takes a lot of effort, and in one go it's not possible to train everybody at the same level. So different people may require different levels of intervention.
Yes.
So if you are
So,
doing this, then the purpose is to avoid complications, right? So that is my suggestion. So
yeah, your suggestion is well taken, but the aim of this particular study was to just see whether the knowledge increases the confidence in taking care of the mothers.
yes, got it.
So
Got it.
therefore, we did not go into the depth of complications and everything.
Right. Over to Dr. Serene.
Yeah, I thought it was more like a CAP survey, post-intervention after they have given these home-based videos as well as those pamphlets. So They were not really focusing on the complications, etc. So if the aim is fixed, just to know about the knowledge that the mothers gain and the confidence level, from that angle, I think the aims are very clear and they're very obvious clinical relevant focus, and they were not kind of going beyond that aim. The intervention was well defined and structured tools were used. They did a pilot study, which they used later, which had a good reliability. And they had multiple assessment time points. That was good because they initially kind of had that pre-test as at the baseline, and then they had a post-test after 1 week and then 4 weeks. So if they retain it by 4 weeks, then that means their retention power is good. Using those, that was also a good point. And they used appropriate statistical analysis, and they had significant, consistent results about both knowledge and confidence. And ethical rigor, they got ethical approval, they got CTRI registration, informed consent, confidentiality was ensured. I think these are good points whenever you're doing any kind of research. But there were some limitations. One, ma'am, I want to clear this convenience sample. You couldn't explain well about the convenience sample. Convenience sample is you had another paper similar to this done before, then you take out a sample size. So if you go into the rigorous of it, you probably will have a sample size which is much bigger, but your intent is just to kind of, focus on very few. So that is the time when you say it's a convenience sampling, because this is the time available, this is the resources available, whatever convenient we could do it, we'll take those many numbers. So uh, that is convenience sampling, and sample size was definitely small. 60 is not a very big sample, or two cohorts of 30 each is not very big sample, because convenience sampling actually limits representativeness. Small sample may be underpowered to detect subgroup effects and increases risk of type 2 error. So in such a case, ideally speaking, you should not take significance at 0.005, you could take it at 0.01. If you do that, then your type 2 errors don't occur. And of course, whenever you do a quasi-experimental design like this, which is non-randomized, there is always a selection and allocation bias. So internal validity is limited in such studies. You did mention, actually, you skipped the slide, and it very clearly showed that there was a baseline imbalance in socioeconomic status in the two groups. It was actually, if I read the slide right, it was 0.0013, something like that. But you brush it off saying that everything was similar, both groups. So that's not the true. So there is some confounding there because of the socioeconomic group. A short follow-up group. I mean, 4 weeks is okay, but to know long-term knowledge retention, you probably need to kind of do it maybe after 6 months. Then only. Otherwise, what we read in newspaper, we remember 2 days and then later forget. And you have excluded mothers or children with comorbidities as well as CNS tumors. That kind of reduces applicability of this to complex pediatric oncology cases. And obviously, blinding was not feasible, and that is why there is a performance and detection bias, obviously. And although everybody has mobile these days, etc., so digital literacy uh, is there, but in very low socioeconomic group, this may not be possible. So, of course, the article has acknowledged the need of alternative delivery formats as well. So, overall, a good attempt, very nice. I think we need to have a more collaborative work with our other side of the team, nurses. And for that, I mean, I give you full marks. Really done great job. Thank you so much.
Thank you, sir.
Thank you, Dr. Sashi.
Thank you.
Good job. Good job.
Yeah, Manoj, if there are any queries on the...
Currently, there is no. We can proceed to next.
So the next paper is again by All India Institute, and this is exploring the correlation between immunohistochemical findings and bile constituents in choledochal malformation specimens. I think Chandramouli is going to talk about it, and I also saw Ajay Verma, who's probably the corresponding author, and the chief whip behind this project, sitting there in the audience. Yes, Chandramali, you might go.
Okay, is my screen visible and am I clearly audible?
Yes, yes.
Yes.
Okay, thank you, sir. Good evening, respected chairpersons, moderators, seniors, and dear colleagues. Warm greetings from AIMS New Delhi. I will be presenting our experience on the bile constituents and immunohistochemistry in colorectal malformations. Colorectal cysts have always fascinated pediatric surgeons because of their complex anatomy and uncertain pathophysiology, pathogenesis. Through our study, we aim to explore the biochemical, histological, and molecular linkages that might explain the inflammatory and proliferative changes seen in this cyst. This is a follow-up study, kind of follow-up study of our previous study by our corresponding author, Dr. Ajay Verma, in GIAPS earlier on the biochemistry in colorectal malformations. Sorry, my slides are stuck a little bit. Let me just escape. Okay, fine. Despite decades of study, the etiology of colorectal malformations remain unclear. Some consider it congenital structural weakness of the bile duct, while others attribute it to the pancreaticobiliary reflux due to an abnormally long common channel. Recent works have suggested inflammation and epithelial instability could drive cystic dilatations and explain the pre-malignant potential observed in these older patients. We focused on 5 markers: COX-2 and INOS for inflammation, MMP9 for extracellular matrix remodeling, PS6 and mTOR for cellular proliferation markers. By correlating this with the bile's biochemical constituents, we aimed to understand whether the reflux chemistry truly translates into tissue-level changes. We conducted this cross-sectional study in AIMS New Delhi from January 2021 to December 2022. We included all patients of colorectal malformations who underwent surgical excision with hepaticojejunostomy. We excluded those with active infection, cholangitis, pancreatitis, or raised leukocyte count to avoid confounding inflammatory bias. During surgery, we collected 5 ml of bile aspirated from the cyst before excision of the the excision of the cyst. 5 ml of the bile we aspirated from the cyst and also from the gallbladder, and immediately stored it in minus 80 degrees centigrade. This was analyzed for amylase, lipase, electrolytes, bilirubin, bicarbonate, pH, and bile salts. The cyst wall was subjected for histopathology and immunohistochemistry for COX-2, MMP9, PS6, mTOR, and INOS, and MMP9. The histopathology, we assess the epithelial ulceration, denudation, metaplasia, and density of inflammatory infiltrates. Now the immunohistochemistry was graded into 2 parameters. Number 1, intensity from 0, that is negative, to 3, that is strongly positive. And number 2, distribution, that is from 0 to 4 based on the proportions of the cells stained. The markers were chosen for specific roles: COX-2 and INOS for inflammatory indicators of inflammation, MMP9 for matrix remodeling and fibrosis, PS6 and mTOR for cell growth and proliferation. The amylase, lipase, sodium, potassium, calcium, and chloride and bicarbonate levels were also measured in the bile. For statistical analysis, we use the Mann-Whitney test for comparing the medians, chi-square test for the comparing the categorical data, and Pearson correlation for continuous variable. We use statistical the latest SPSS version at that time. We studied 30 patients with median age of 72 months, including 13 boys and 17 girls. All had type 1 colorectal malformation and underwent complete excision of Roux-en-Y hepaticojejunostomy. The mean hospital stay was 5 days and all recovered uneventfully. Clinically, we found that a palpable lump was present at presentation and which correlated strongly with abnormal pancreaticobiliary junction length more than 10 millimeters. This finding links the anatomical abnormality with the clinical presentation. On biochemical analysis, Sorry, this was the previous slide. Just the slides got stuck. We found that the palpable lump was strongly correlated with the abnormal length of the ABPMJ. On biochemical analysis of the bile, amylase and bilirubin levels showed significantly increased levels in patient with a common channel length more than 10 millimeters. The potassium and calcium levels were also altered in those with stronger COX-2 expression, implying the membrane damage and inflammatory exudation. These changes reflects the reflux of pancreatic enzyme into the biliary system, leading to the bile that is chemically more aggressive, a precursor of epithelial injury and metaplasia. On histological analysis, most specimens showed chronic inflammatory infiltrates with varying degrees of fibrosis without overt dysplasia, however. Immunohistochemically, COX-2 and COX-2 was positive in 18 out of 30 cases, MMP9 in 17 out of 30, and PS6 in 18 out of 30, while mTOR and INOS were negative in all the specimens. The intensity of COX-2 expression was significantly associated with ABPMJ length more than 10 millimeters and with elevated amylase, potassium, and calcium levels. MMP9 and PS6 also showed increased level in those specimens and showed a positive correlation with the levels of lipase, suggesting its role in extracellular matrix remodeling. PS6 positivity observed in more than half of the specimens signifies active cellular proliferation even in pediatric cyst walls. The MMP9 positivity suggests its role in extracellular remodeling and matrix remodeling. The levels of the COX-2 expression was significantly associated with ABPMJ length more than 10 millimeters and with elevated amylase, potassium, and calcium levels. All the specimens were negative for INOS and mTOR. These findings emphasize the chronic inflammation is a central role in the pathogenesis of colorectal malformation. The expression of COX-2 and MMP9 supports a structural inflammatory cycle. Pancreatic reflux induces epithelial damage, which triggers the inflammatory repair and fibrosis, perpetuating cystic dilatations. MMP9 are gelatinase that breaks down the extracellular matrix and facilitates remodeling, further weakening the duct wall. This pattern resembles cyst early changes in the biliary carcinogenesis described by Cabati et al. And LV et al., suggesting the pathogenic pathways of inflammation and malignancy may overlap. Similarly, PS6 overexpression indicates upregulated ribosomal activity and enhanced protein translation, especially a hyperproliferative mucosa. In our cohort, this occurred even without visible metaplasia, suggesting that cellular instability precedes the histological changes. The absence of mTOR positivity could imply that our pediatric cases represents an early phase before full activation of the mTOR S6K pathway that drives the neoplastic transformation. Collectively, the triad of COX-2, MMP9, and PS6 points towards a microenvironment primed for pre-malignant progression, reinforcing the need for lifelong follow-up even after surgical excision. To summarize, COX-2, MMP9, and PS6 were significantly overexpressed in colorectal malformation specimens. Their expression correlated with ABPMJ length and bile, amylase, and bilirubin levels, establishing a biochemical pathological bridge between pancreatic reflux and tissue injury. Hence, inflammation and proliferation emerge as a key mechanism driving the disease, potentially explaining its long-term malignant risk. Understanding this pathway may one day open avenues for molecular prognostication or target anti-inflammatory intervention in selected patients. Thank you so much for providing me this platform to present our study. Thank you.
Yeah, thank you so much. Dr. Sushmita, wish you say something before I read out what report I've made.
Yeah, thank you, Dr. Chandramouli. Both the presentations actually have been very, very smooth and to the point. Just some few observations. One is you have mentioned about these five markers on immunohistochemistry, biochemical analysis, enzymes, and immunohistochemistry and histopathology. But did you correlate this with the culture, bile culture reports also? Because many a times there is inflammation is preceded by infection, which may not be a fulminant infection, but there may be some infection. So was any culture done, bile culture done at any point of time?
It is a very interesting question, ma'am. Though we do not have a bile culture for these specimens, but what we do have, we excluded the patient who had clinical features of cholangitis and even a raised TLC count. We have excluded those patients. Actually, in this study, we included around 50 patients. 20 were almost 20 were excluded on the clinical background itself. Definitely, we do not have a positive culture of the bile. Yeah, yes, ma'am.
Okay, okay. So that was my first observation, that that part was missing. So you have clarified that. Another thing was you mentioned about these five on immunohistochemistry, these five markers. So why were these five only selected? And meaning on what basis were these markers selected?
Yes, ma'am. There are two reasons behind this thing. Number one, we did a kind of unofficial systematic review of this, the previously published literature. We find out what are the markers which are shown in colorectal cyst and which are the typical inflammatory markers in the this thing gallbladder and this pathway. Number two, we selected those markers which are available, like the kits are available in India, and number three is the funding. Like we got an intramural fund, and the thing is that we have to arrange the funds for all the 30 patients. We did those markers which are available in India with a reasonable fund.
So how much fund was needed? Now that is not part of the article, but just being inquisitive as to how much was the funding required per patient for these markers.
Sorry, ma'am. It
No,
is difficult
Chandramouli,
for
I
me
will
to
answer.
answer.
Chandramouli,
Yes.
good evening, ma'am. Ma'am, this was an intramural project and funded by AIMS Research Section. So we got 8 lakh for this project.
Oh, okay, great. So have you acknowledged it in because I may have missed that.
Yes, ma'am, we have acknowledged it. The
Achha.
last line, I think, we have.
Okay, fine. I may have missed it. Yeah. Yeah, thank you. There is something else which you mentioned about positive and negative controls. If you can explain that as well. In your article, you have mentioned about positive and negative controls.
Yes, ma'am. Definitely, ma'am. We did the internal validation with the gallbladder bile. So gallbladder bile acted as the internal control validation for this.
Okay. Over to Dr. Sareen, please.
Before I get into the strengths and limitations and other issues, I mean, the exclusion criteria were not very clearly mentioned. Now he mentions that the 50 patients were taken and then the 20 were excluded. That's not mentioned in the paper as such. Beyond the strengths and limitations that I'll speak, most importantly, the point I wanted to raise is that nowhere in the paper it is really written that these many 30 patients, whether all 30 patients you could actually demonstrate anomalous pancreatic biliary junction. I went into my own records and I found that APBJ could not be demonstrated in more than 5 to 10%. Then I called up my GI surgeons, GB Pant Hospital, where I had worked before, and they also mentioned that they kind of see ABGP on their MRIs only in about 40%. So there is an assumption which is not mentioned in the paper as such, but I think there is an assumption that they could see the APBJ in all their 30, that's 100% of the subject. Is that correct, Ajay?
Sir, APBJ was calculated. We were able to, because all of these patients underwent MRI at our institute only, so we could measure APBJ in all patients. But I think only 12 patient it was more than 10 mm, and in remaining it was less than 10 mm. So arbitrarily we have taken 10 mm as the cutoff.
10 and my point is that with the kind of MRIs that we receive, of course, some of them are done outside and some of them done at home. Our pickup of APBJ and to kind of measure the length of it is so I can't do this study at my place at all, you know. So it's very good that you all could have all 100% MRCPs telling you the length of APBJ. So after having said that, I will go into the strengths and limitations that I've jotted down for the paper. It's of course a novel contribution. It's the first time somebody has tried to kind of associate with these markers with the inflammation proliferation pathways in CDC. So it's that where it really scores well. And there is a use of multimodal testing. You have done biochemical analysis, histopathology, immunohistochemistry. That's also very nice. And you picked up the markers, as he said, that they did a systematic review, and you picked up the plausible indicators of inflammation, tissue remodeling, and cellular proliferation. And you use all consecutive patients. So there is no bias that way. I mean, there's no selection bias. Which is good. Again, it is a convenience sample. There is, because anyway, such a study has not been done in the past. They probably could not have worked out a sample size. So it's a convenience sample. Detailed methodology of all immunohistochemistry procedures, scoring system, analysis techniques are described, which is good. And I mean, overall, you're trying to identify a plausible pathophysiological mechanism behind the inflammation, and you kind of hypothesize that the long-term inflammation will eventually cause carcinogenesis also, which would probably seen in the adult. That is another issue. You know, we're talking about cancer and we're not talking about including adults having CDC. If you had collaborated with the GI surgery or general surgery department, you could have probably taken those patients also. Even now, you can encourage them to do a similar study to see how things go. So as regards the some limitations, of course, you've already explained that why funding and other issues were there, and that's why the sample size is small. Again, to say the same, I mean, you all have acknowledged that in your paper that sample size is small, and that, as I said before, this is the type 2 errors. So you probably could have picked up the significance at 0.1. It's a cross-sectional design. As we're talking about inflammation, carcinogenesis, so we should have actually had a very long longitudinal follow-up of these patients. Such a study is possible and probably can still be done if you could have these patients, under your long follow-up. And there are potential for confounding as age differences, etc. There is a lack of healthy or disease control as such, although he tried to explain that the gallbladder versus choledochal bile were compared. Um, no MTR positivity was seen. Limited generalizability because you included only a CDC type 1 and not other types of CDC. Is it a selection bias or is it that the consecutive patients came as type 1 CDC only? Ajay?
All of our patients were type 1 only. We didn't find any other types of cortical cysts.
Yes,
So
that's possible.
that is what.
That's possible. And then I think because of the funding, otherwise you could have used some other markers like CRAS, P53, IL-60, and F alpha as well, because we were talking about carcinogenesis. Um, Again, about the statistics, this study uses correlation and regression, but does not adjust for multiple comparisons of potential covariates, which may inflate the likelihood of false positive findings. So that's it. I mean, what I have to say. So it's a whole concept, um, uh, but I think if you really want to put it into from to the bedside, then you probably also need to have some adults and all other ages kind of included, and then studied for longitudinally for long. You're still there in the department for next 20 years, I'm sure. Go on for 10 years and then come out with another great paper, which will probably win awards.
Thank you, sir. Thank you for your comment. Your comments are well taken. So I actually talked to my GI surgery friends, and they told me that they also have not seen any such malignancy patients in colorectal cyst. So it was very difficult to get a adult
Problem is,
patient.
I think why colorectal cysts, when they were not excised and just barely drained internally or whatever, those are the ones who had continence inflammation going on for decades, and they're the ones who by 40s used to kind of have cancers coming in. So because that is not the way we treat patients now, but you could still have patients coming in at the age of 40, 45 years with CDC. I mean, I've heard it from a GI surgeon friend. So if they kind of get such elderly patients, I mean, they should also be longitudinally followed up. Otherwise, there's no point then talking about carcinogenesis and correlating it with the inflammation. Really, that's my view.
Thank you, sir.
Yeah.
Let's go to third paper, Yogesh.
Yes, please. The third paper is from Division of Pediatric Urology, Sanjay Gandhi, Postgraduate Institute of Medical Sciences, Lucknow, Ansari and all. I think Anvesha is there to speak, and they're basically talking about assessing surgeon-reported physical discomfort in open versus robotic ureteric reimplant, a comparative analysis.
Am I audible?
Yes.
And my screen is visible?
Yes, ma'am.
Okay. A very good evening, all dear judges, seniors, and colleagues. So, I will be speaking about assessing surgeon-reported physical discomfort in open versus robotic ureteric reimplantation, in which we have done a comparative analysis. So, a short background about reflux. VUR occurs in 1% of the pediatric population, which leads to impairment of renal function. I'm sorry, I'm unable to see the video panel. Okay. So there has been a dramatic evaluation in the management of vesico-ureteric reflux, whereas initially it was surgery as a primary intention, and then we moved to conservative approach with active surveillance and antibiotic prophylaxis. Initially, open ureteric reimplant was the only surgical method. Thereafter, we moved to laparoscopy and thereafter robotic in the 1990s. My screen seems to be frozen. Okay. Uh, why we have moved from open to laparoscopic and then robotic? Initially, the open intravesical ureteric reimplant causes a greater discomfort to the patient, leading to a lot of bladder spasm and hematuria. Thereafter, when we moved to laparoscopic reimplant to circumvent this problem, challenge was faced in the form of limited bladder space, which led to clashing of instruments, especially in bladders of very small capacity. Now, robot-assisted laparoscopic ureteric reimplant has provided easier movement in limited spaces because of the wristed arms, providing us with 7 degrees of freedom. So, why did we do this study? There was a landmark study by Hansraj et al., which spoke about the effect of prolonged smartphone use in the general population. As all of us surgeons using loops will know that our OT table is fixed down to accommodate for the optical length, we face something of the same sort that Hansraj has described as stress neck, which is the loss of the natural curvature of the spine due to repeated wear and tear, leading to degeneration and even earlier surgeries. This, which he described as stress neck, is more seen in surgeons performing open ureteric reimplant, which I have designated by this orange line, wherein the tilted neck, circumvents a pressure of 15 degrees at 20 at 15 degrees. It circumvents a weight of 27 pounds at 30 degrees of 40 pounds. at 45 degree of 49 pounds and at 60 degrees of 60 pounds. So whenever a surgeon is operating in an open reimplant, his neck is tilted in between 45 to 60 degrees. And in the robotic reimplant, the surgeon is seated comfortably at the console at a physiological 15 to 20 degrees tilt at the cervical spine, plus his forehead is supported on the console. So we extrapolated the study outcomes onto surgeons using optical loops to find out if ergonomically robotic surgery was better in open compared to open aortic reimplant. Ergonomic superiority of RALR is undeniable, but no studies so far have had an objective head-on comparison with open aortic reimplant. Even though the European and the American Urological Association guidelines are given out in detailed form, they do not recommend RALR as a routine procedure yet for surgical correction, mostly due to lack of reports and evidence. Also, there are wide-ranging success rates reported for RALR depending on surgeon experience, and a very few studies exist that investigate the efficacy of robotic versus open reimplantation. So far, we know this is the first comparative study between ergonomic ease of intervention between open and aortic reimplant following the cross-coherence reimplant technique in North India. So our objective was to compare surgeon-reported health outcomes between open versus robotic reimplant in terms of three parameters, that is neck stress, shoulder pain, and generalized fatigue. And simultaneously, we also compared the outcomes of robotic versus open aortic reimplant. Our methods, it was a single surgeon prospective comparative study which was conducted at the Division of Pediatric Urology at SGPGI from January 2016 to July 2023. We obtained institutional ethical committee approval, and written informed consent for participation was taken from all candidates. We included all pediatric patients undergoing unilateral open intravesical or robotic transvesicoscopic Cohen's cross-trigonal ureteric reimplant. We excluded bilateral cases. We excluded primary obstructed megaureter or refluxing megaureter requiring tapering of the ureter, any previous surgical intervention for correction of the VUR, and cases requiring conversion to open technique. Patient families were allowed to afford to choose open versus robotic intervention based on personal preference and affordability. And we had explained the prognosis and outcomes as per our institution standards to them beforehand, as in they were counseled beforehand. The initial evaluation, we took a history about prenatal diagnosis, any urinary tract infections, antibiotic prophylaxis that the child was on, a USG, KUB, a VCUG, and renal scintigraphy was obtained. Also, free uroflowmetry and post-void residue was done, and we evaluated for symptoms of bladder dysfunction and previous endoscopic treatment in the urethra. In perioperative parameters that we evaluated for blood loss, any conversion, operative time in minutes, surgical ergonomics, neck stress, shoulder pain, and generalized fatigue was scored by the operating surgeon on a VAS score, and the surgeon took the questionnaire immediately after the procedure was completed. In postoperative parameters, we evaluated the required daily dose of intravenous paracetamol at 15 mg per kg for adequate analgesia, surgical course, and length of hospital stay in days. Our minimum follow-up was 6 months, median follow-up was 24 months. Success was defined by the absence of documented febrile UTI or absence of recurrence of VUR objectivized by VCUG in both groups, and VCUG was only done in case of recurrent UTI or febrile UTI. Sample size calculation, we have not done any formal sample size calculation. However, based on our observed standard deviation of 0.1 and detecting in between group difference of 1 to 2 points with pain scores at 80% power, we assume that the approximately 24 to 94 patients per group would be okay to, depending on the assumed defect size, and our achieved sample sizes of 30 in the open group and 21 in the robotic group were falling within this range for detecting larger effect sizes. Analysis, we did a statistical analysis using the chi-square test for categorical variables and student t-test for continuous variables, took a p-value of less than 0.05 as statistically significant. We use the statistical modeling approach to assess the impact of surgical technique on surgeon-reported outcomes. So we use the ordinary least squares regression model in the Python stats models library to investigate the relationships between the independent variables of surgical technique, operative time, and length of stay with the dependent variables, that is neck stress, fatigue, and shoulder pain. And we also applied the Bonferroni correction to account for multiple hypothesis testing on our statistical analysis. So coming to our results, preoperative parameters, as we can see, the age was matched. We had in the open group a mean age of 7.3 years, and in the robotic group a mean age of 5.12 years. P-value was not significant. 80% males, 20% females in the open group, 72% males, 28% females in the robotic group. A total of 30 patients in the open group and a total of 21 patients in the robotic group. The preoperative bladder capacity was 290 ml on an average in the open group, 252 ml on an average in the robotic group. Intraoperative parameters, as we can see, the preoperative bladder capacity, as we have discussed, the intraoperative blood loss was 32 ml in the open group, 43 ml in the robotic group. Mean OR time was significantly higher in the robotic group, 170 minutes versus 146 minutes. As we can see in the median rating, I will share in the appendix later the whole reporting. The median rating for ergonomics was significantly different in the robotic group versus the open group. In robotic group, it was lesser by 2 points consistently across all three parameters of neck stress, shoulder pain, and fatigue. In postoperative parameters, we evaluated the length of hospital stay. In the open group, it was 6.4 days. In the robotic group, it was 4.2 days, which was significantly lesser. Analgesia requirement was not very different, 3.5 times a day versus 3.8 times a day in the robotic group versus the open group. The mean surgical cost was definitely much higher in the robotic group, 30,000 in open versus robotic 1,20,000. Surgical success was comparative in between both the groups, which is about 96% in the open group, 95% in the robotic group. One patient from each group developed recurrent UTI. Cystoscopy was routinely done in the robotic group on table. The mean OR time was significantly higher. For this reason is something of our own observation. All robotic procedures could be performed without any conversion to open. On follow-up, one child from each group presented with repeat episodes of UTI despite surgery. So it was a comparable level of success for both procedures. Regression analysis details. When we performed regression analysis details to compare the robotic versus open approach with neck pain across all pain measures of neck pain, of neck stress, fatigue, and shoulder pain, robotic group consistently scored lesser on the VAS score compared to the open, and it was significantly different. The amount was significantly different on the VAS scoring. On operative time, there was a significant positive association with fatigue and shoulder pain, but not with neck stress. In the length of stay, there was no significant predictor across all models, as in the length of stay was not affected by neck stress, fatigue, or shoulder pain. The multivariate models demonstrate that the robotic approach benefits persist after controlling for procedural and recovery factors, strengthening causal inference despite the observational design. Coming to discussion, we could not find many studies which could give us a background on the topic that we were discussing. However, we have found a few, like a handful of studies, one done by Deng et al., who has also reported significantly longer surgical time for RALR compared to open, significantly fewer length of stay and post-operative Foley placement time, and non-significant estimated blood loss, success rate, complications, and post-operative analgesia usage, comparative to our study. Another study done by Kurtz et al., he compared 1494 open ureteric reimplants versus 108 RALR cases in 17 hospitals across the US using the Premier Hospital database. He reported that the median operative time was significantly higher in robotic procedures. Incidence of 90-day complications was significantly higher. Median hospital cost was significantly higher in robotic procedure. However, Kurtz et al. Also said that 51% of the robotic cases were done in between 2012 to 2013, whereas this whole study was spanning across 2003 to 2013. So in the last 1 year of this whole study, 51% of the cases were performed. And he has noted that the variability in complication reported may be due to the differential uptake and experience amongst the centers as they're integrating into a new procedure into their practice. Also, they have mentioned that reporting bias is present in the Premier Hospital database, and this lacks review standards for reporting complications. So these might be two confounding factors. Another study done by Marchini et al. Has reported that RALR is associated with longer operative time, shorter duration of urinary catheter drainage, fewer bladder spasms, and shorter hospital stay compared to those undergoing the open reimplant technique. And our observation was that the preoperative cystoscopy and the transvesicoscopic port placement appears to contribute to the increased OR time for RALR. The time required reduces as the surgical team becomes more attuned to the process of gaining access. Also, we found significantly worse outcomes in terms of neck stress, fatigue, and shoulder pain for all our models. And OR time is a significant contributing factor to both fatigue and shoulder pain, indicating that longer operative times will contribute to worse outcomes in these areas. The limitations of our study, we have a small number of patients. It is a single center, single surgeon, non-blinded study. Unmeasured confounders are present like patient BMI and ureteric anatomy. It is a single surgeon rated score. The questionnaire is unvalidated. There is a limitation of our analysis in the presence of multicollinearity amongst the independent variables, which impact the precision and reliability of the estimated regression coefficients. We require multi-center trials with validated questionnaire-based ergonomic rating from multiple equally accomplished operating surgeons, or even better, by an independent observer with greater number of study subjects to establish firmly the efficacy and ergonomic superiority of robotic reimplant. So to conclude, the robotic associated reimplant is feasible, offers success rates comparable to open surgery. It follows the anatomical principles, minimizing possibility of hematuria, neurourological damage, and the subsequent bladder dysfunction. The surgical ergonomics related to musculoskeletal symptoms in the surgeon are more substantial in open surgery. Thank you for your patient listening. This is my appendix of all the pain ratings and according to the VAS score by the surgeon done in postoperative period.
Yeah, Dr. Sushmita, you have to say a few things.
I do, but I guess we are already past 10. So I think you can go ahead, please.
I think we started only at 9:10. We were talking other things than the papers. So it's okay. So I think the authors and Anvisha, uh, we should focus on what you have aimed to, and your aim was assessing surgeon-reported physical discomfort. So there's no point talking about the results and this and that. And there is a question by Dr. Rasik, whether during this period you also did laparoscopic, not using the robot instruments, but just ordinary laparoscopic instrument. Was there a cohort like that too?
So no, we have moved transvesicoscopic laparoscopy. We have moved entirely from that into robotic.
No, that's
We were
true.
not doing transvesicoscopic. We were doing extravesical laparoscopic, sir.
Okay, that's right. Okay. So the one thing which I must say from the research point of view, one of the exclusion criteria of yours was that a patient is converted, that has to be excluded. No, there's something called intent to treat. You do not exclude a patient that converted. It stays there. Although when you do statistics and all that, you could mention them separately as a subcohort. You cannot exclude them as such, because inclusion exclusion criteria already mentioned beforehand. Which patient would be excluded because you have to convert is not known before. So I think that's one thing that mostly you already mentioned most of the strengths and most of the limitations of your surgery. I'm not bothered about the cost bit because your aim was not about the cost. Cost obviously is 4 times more. But the problem, limitation, major limitation is that it's a single surgeon, single center design, sample size is small, and it is surgeon self-reported discomfort, and it's not a very validated VS scale. It's a kind of non-validated. You haven't done a pilot study also. So non-randomized patient allocations there. I'm sure 2016 onward till about say 20, there may be open, and now we're talking about the robotic and every. So those things are there, and I think you mentioned all of them. Most of them you already mentioned before. So I will not go into all those details. So with that, I thought this paper is also a little different because now we're talking about ergonomics, which we usually don't talk about. By the way, I have never used loops in my entire career. I'm 63 years old already. So, but I do find my younger colleagues kind of, they kind of, at times I feel that will touch the OT table itself, they're almost turning their whole neck down, and, the light is also kind of stopped because of their posture. So postures in theater are very, very important eventually if you're talking about these discomforts, even in open
So,
surgery.
if I may make a comment here, what we realized was when we are doing the ipsilateral mobilization, as in when the surgeon is mobilizing the opposite side ureter and the assistant is trying to see the ipsilateral ureter being mobilized, it's very difficult for this person because this person has to stoop across the table, which has been completely circumvented by the fact that, the assistant can see everything on the screen, whatever is happening in transvesicoscopic, which is one advantage we saw as
Yeah, but one
residents.
confounding factor is the width of your OT table also. I mean,
Yeah,
one, we have babies right from 3 months old to 18 years old. So what is the length of, what is the width of the table? The tables come with all kind of widths. I mean, my table that I used in Maulana Azad for almost 22 years was very, very narrow. And the table that I use in Lady Harding is very, very wide. So all those things, these are all confounding.
indeed.
We
Yes.
keep in mind. But anyway, somebody is now trying to study something different, which was the encouraging point, and that's why we chose your paper as one of the papers. Aren't you from pediatric surgery background?
Yes, sir. I
Yeah.
am from Safdarjung.
Oh, you were in Delhi itself. Okay, fine. Thank you so much. So with that, I think if we have more comments, I've already included Rasik's comment, and she says no, they don't use.
Yes, so to reply to Rasik sir's comment, we actually this paper is part of a very big study. So we are expecting to produce more papers out of the data that we have. We indeed have laparoscopy also. We also have bilateral
Are
data.
you talking about you're doing salami publication, which is very, very unethical?
No, 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 sir. This is just two comparative amounts that we have, two comparative data sets that we have chosen
I mean, the
out
other
of
one
this.
is laparoscopic versus robotic, is it?
Uh, I have no idea because that is, I think they are still collecting data on that. We have data for this amount of duration that we have. I think extravesical is a separate topic
Okay.
that they are expecting to produce.
All right. Right.
Okay, so
I,
two
sorry.
Yes, ma'am.
thoughts cross my mind, and I think I should say it over here with all due respect to everyone, including the surgeon. I'm not sure who was the surgeon.
Our
I'm
friend
just
Ansari.
wondering, Dr. Ansari, okay. I'm just wondering, you've ruled out any pre-existing condition of the surgeon in which they develop pain in the neck and the shoulder in that position. I know a few conditions which cause this. That is why I'm
So
asking. So
far,
you
so
have
far, I know,
ruled
ma'am, sir
out,
has diabetes. I am
please
not
rule
aware of
out.
anything else.
Please do rule out. And the other one is apart from the presentation, and that is that we all need lot of muscle strengthening exercises, especially the back muscles, which we don't do at all because our entire spine is supported by our back muscles, and we don't tend to do it. So this is apart from it, but you are younger, so you can start off from now itself. Thank
Indeed.
you very
Thank you, ma'am. Thank you.
The back needs to be strong.
Yes.
Yeah, I think we had very good discussion. And is Vijay Kundal around or?
Yes, sir. Yes, sir.
Yeah, yeah. So maybe you can give word of thanks, and then moderators Arvind Sinha and myself will continue with the meeting and select the best paper. Yeah, Vijay, please go ahead.
So, respected Editor-in-Chief, Secretary, IAPS, moderators, presenters, and participants. So, on behalf of the JIPS Editorial Board, I extend my sincere gratitude for making today's JIPS Abhigyan, this online research paper presentation session, very meaningful and successful. A heartfelt thanks to our Editor-in-Chief for the continuous guidance and Secretary IPS for the constant support, and a special appreciation to the moderators for their excellent session and brainstorming and vibrant academic interaction. for all the three papers. So with this, we formally conclude the session. Thank you once again. I think most of the participants, they can log off from presentation, except the moderators and editor-in-chief and coordinator, sir.
And
Yeah.
Manoj,
Manoj sir will be there, sir. Sir, I think recording is done from my side. Should I pause the recording or it will
No,
continue?
no, you switch off the recording now.
Okay, I'll stop it.
Yeah.